Okay. Okay. So keep me posted with any issue and the if any technical issue or any voice interruption, keep me posted on the chat so I can correct that as we go on. Um, so today, as we agreed, we will be discussing the insular. Uh, and this structure is really a mystery because it's hidden inside on the undersurface of the cerebral cortex, as we all know. And from a clinical neurology point of view, it is something that we have very few localization syndromes related to it. So there is no symptom that happens. I can think in my mind and say that this is an insular lesion. This is not per the textbook of clinical neurology, clinical examination, and clinical localization. So we have symptoms that might happen as an association, but not particularly very crucial in terms of localization to this region. Uh, but on the other side, you can find that this cortex is involved in some autonomic regulation, in some emotional regulation, and in some sensory experiences such as the taste, GIT symptoms, all of them, visceral symptoms, I would say. They are involved in that, but they are not particularly symptomatic in terms. So you can't say that a person who's suffering from a GIT upset and you localize it to the insula. So this is not particularly relevant. However, from an imaging point of view, this structure is very diagnostic. So because it tends to be affected differentially in different pathologies, and that's why you can localize it. You can localize the pathology. Or you can make a diagnosis here, like for example a stroke or a carousel, for example, can involve regions closer to the insula, and this is why it is very appealing for us to know the anatomy, the outline of this structure, and how we can identify it in the scans. So we will start with the basic anatomy. So as you know, the insula means an island in Latin. So it is deeply buried within the cortex. So for this particular side view of the brain, so we needed to split this lower part. Let me try and see if I can increase the thickness of this pen. Yeah, good. So the originally the Sylvian fissure should be here, and on the top there is the frontal, and that's the parietal, and in the middle there is the central sulcus. So we had to raise this part, and to raise the lower part of the temporal lobe to make it happen. And if you can imagine that as two lips of a mouth, this is called the opercular region. The opercular region is the two cortical components that surround or at least that hides the insula. And these two cortices, the opercular components, the top part is called the top part is called frontal operculum and parietal operculum, and the lower part is called temporal operculum. They are highly structurally, functionally relevant, because this is as we have discussed in the frontal lobe, this is Broca's area, and this is also the relevant side of the parietal lobe is closer to, if you go slightly posterior, this is closer to the language areas, and this is also some sensory regions on the sensory strip. And on the lower side, this is the area involved in auditory processing and language processing. So the opercular region is very important in terms of function. So you need to uncover both. So you need to pull this side and that side to be able to see to the insula, and the insula is a triangular shape. So this is an imaginary line of the three sides of the triangle, and it is in we have five fingers if we can compare it to the hand. So there are five fingers, three short gyri and two long ones. It's easy to see. So as we go on, it will be easy to identify them. But it's just you need to see from the insula, you will need to see two bigger ones posteriorly and three smaller ones on more anterior, and they are separated by a deep sulcus. So this is simply the insula. So in the top side of it, it is wide, and in the very lower part, it is narrow, closer to an apex. And pretty much that's it. So there has been some studies that relate to structural connectivity and the functional connectivity of these regions, but they are not from a clinical neurology point of view. You cannot make a diagnosis based on a symptom that is very, very localizable to this area of the brain. So it is not particularly working this way. If you follow the cellular architecture, some of them will be involved in gustatory sensations, some of them will be involved in emotions, but they are not that. As I told you, this is not diagnostic on their own. And here is how they look like, how the gut sulci gyri appears in the axial cuts, which is pretty much what we care about. There is in the cross-sectional anatomy, it is really important to focus into the following. What I will do is try and zoom a little bit here, get it closer to you, and remove the markings. So these are the three little fingers, and this is one of the two big fingers. And we know that, so if this is the insula, it is hidden underneath the operculums, the upper operculum, which is a frontal and parietal, and the lower operculum, which is temporal. Because we can see here a sylvian, this is a sylvian, and because there is a space between an anterior gyri and posterior gyri, so this is a sylvian fissure. So likely this is an inferior frontal region, and this is immediately below it. This is part of the temporal, and this is the parietal region. It is really, really, really important to remember the anatomy of the rest of the medial structures to the insula. So from the insular cortex, there is a ribbon here. Okay, and this is colored. We will see in subsequent images that we may see the ribbon rather than the colors. But immediately below it, there is a white matter region, and there is a tiny, tiny, tiny gray matter structure, as you can see it here. I'm going to outline that. And there is another yellow or white matter region, white matter area, and finally you will end up with the lentiform nucleus. Each part of that has a name and maybe relevant functioning separately. So we know that this is a lentiform nucleus, and this is the internal capsule here. So what lies immediately behind the lentiform is the external capsule. This is the external capsule. And there is this very, very tiny bit of a gray matter structure called the colostrum separates the external capsule from the extreme capsule. Like as if we don't have enough terminology. This is too many terms, too complex, I would say. But at least they are not helpful in terms of function. So not every single fiber, of course, every single fiber tract has a function, but they are not, again, they are not related to localization for us. But it is important that you have a look in every single part of this anatomical area to make sure that this area is healthy looking or otherwise can be affected by pathologies. So let's remove all the markings again and try one more time to pinpoint every single region. So this is the cortical ribbon, and then extreme capsule, gray matter colostrum, external capsule, and then lentiform nucleus, and then at the very medial side, it's the internal capsule. Let's try and have a look on a normal appearing brain scan. I think I have one here. Okay, and let me completely remove these markings. Let's consider first the axial cuts. This is a T1, high resolution T1. And if you are a keen attendee to this teaching, you will know that this is my brain. So we before we see the sylvian, this is a frontal and a parietal lobe. I'm not going to go into this this time. We have extensively discussed that in the previous couple of teachings. But once you start to go downwards from the top of the brain, you slightly go downwards towards the temporal lobe. The first structure that outlines the temporal lobe is the sylvian fissure, and here is where it should be now. So we'll choose a yellow color, the boldest I can do. I'll see if I can. Okay, that's better. Okay. Okay, so here is the beginning of the sylvian fissure. So, and let's revise what we do know. Can you see the markings, by the way? Okay, okay, I got that. Here, all drawings, and makes this a little bit wider. Okay, so this is the beginning of the sylvian fissure, and just to remind you as well. So if we draw the brain in this way, and we try to take few slices with this orientation. So the first thing, if you go from anterior to posterior, so you will face the frontal lobe first, then sylvian, then temporal lobe, then by the end you will reach the parietal lobe. And again, here's the exercise. So this is frontal lobe until it is interrupted by the sylvian, and this is a temporal lobe, and this is a parietal lobe. So let's take them off and continue a little bit downwards. Okay. So as you trace the sylvian, you will find that the sylvian is developing a cortical area that runs this way. Again, let me change the markings one more time. So you will find the insula that the sylvian is extending to the hidden cortex underneath here. So let's remove that and have a look yourself. So this is the beginning of the insula. Sorry. Okay, so this is the beginning of the insula as it starts here. It's still interrupted, the partial volume, but what we do know is this is a frontal lobe, and this is a parietal lobe, and this is the central sulcus, and this is sylvian fissure, and what lies beneath is a temporal lobe, and then posteriorly this is the parieto-occipital region. So let's clear that and go a little bit to the three landmarks or the main gyri we were trying to identify in the insula. So here may be a good example. So this is a big one and another big one. These are the two posterior gyri, the two big fingers that is in the posterior region of the insula, and then you will have likely smaller three gyri here. Again, on the other side, it's 1, 2 big gyri, and 3 little smaller gyri. The distinction between each gyrus is not important, but the overall appearance is important for you to visualize nicely. If we try with the underlying, to outline the underlying regions, so we can see there is a white matter tract here, but I couldn't see the colostrum so far. So it is just an external capsule and part of the lentiform nucleus. I think this will, as we go slightly inferior, this will become more apparent. So like here, for example. So here there is a ribbon for the insula, and then there are some white matter fibers, and then there is a dark area of a colostrum, and then there is the external capsule, and then the lentiform nucleus, and then finally the internal capsule. This nice appearance is really important for you to memorize in your mind, because they are easily disturbed with different pathologies, and at that moment you will be able to localize lesions more easily in this region. And again, this is a frontal lobe, and this is a temporal because it is posterior to the Sylvian fissure, and these are the very, very bottom of the posterior of the parietal region. So there's no much of anatomical landmarks to speak about. So these are pretty much what we need to do, what we need to see. And what we will do next is that we will discuss the different appearance of this region in different pathologies. So I'm going to turn back to a few examples on the PowerPoint. So any spot diagnosis here? Can anyone tell what's going on? You can chat, or you can just unmute and speak out. Maybe it's difficult, but maybe if we can go a little bit downwards, it can be. Cerebral edema, yes. It's a right MCA. That's correct. The only difference between the right and the left hemisphere is the very, let's try and zoom a little bit again. See the difference. So here there is a cortical ribbon on the outside, and there is a rim of insula, still not much complete, but there is no insula here. So this is an insular ribbon sign. This is an early insular ribbon sign, and you will be able to see it more easily as we go downwards. And actually, there is no gray-white interface, gray-white differentiation in this part of the brain as well. So you can see a cortical ribbon here, but not here at all. And again, of course, on the two sides, this part of the scan is really tricky because it looks like there is edema on both sides, but the cortical ribbon is very well developed here, but it is lost on this scan, on this hemisphere. But here there is a definite difference. You can find an insula. Likely there is a ribboning here, and likely there is a lentiform here, and surrounding white matter in between. There is no single structure related to what we have been studying in the last few minutes. So there is no ribboning, there is no Sylvian fissure by any mean, and there is loss of gray-white differentiation on the outside, and this is definitely a middle cerebral. Looks like a middle cerebral in an acute stage. Let's say let's do a little bit going downwards. Here there might be an insula, and there might be an insular region that I can localize here. There is a difference because the sulcal space here is wider, but it's not just the sulcal space. It is also the differentiation between a gray and white in this region and a gray and white in this region. Here and there. I will just remove the markings and just compare it with your own eyes. So you can here outline on the left hemisphere. So you can outline a cortical mantle or a cortical ribbon and a very, very slightly change in signal, which denotes the white matter tracts or the white matter fibers. But here there is a completely no differentiation. There are completely no differentiation between the cortical ribbon, for example, as first, but also to the deep basal ganglia. I can here broadly outline the lentiform. It's difficult. It is the differentiation is not that big, but it is doable, and you can train your eyes to get it. So there is a lentiform here, lentiform there, is not as outlined as to the other parts. Let's try for what does it mean to have an absent insular region in the CT or in an MRI. This is the aspect score, and we have the operculum have three scores, three numbers, or three scores as three, and the internal region, the caudate, lentiform, and internal capsule has their own three, and the insula lies in the middle and has one on its own. So three in, three out, and one in the middle. And on the top, there are the three of the frontoparietal region. So it is because we don't see a sylvian anywhere here. So this is frontoparietal and parietal region. So this is simply the aspect score that's commonly used in stroke medicine. And you can also help yourself identifying the major vessels or the major branches of the middle cerebral in the insular region as well, because this is an M1. And once it starts to divide into a superior and inferior divisions, it usually happens in the insular region. And when it is thrombosed, as in this case, you will find it as a bright, dense MCA sign as well. So you can in the insular region, you can visualize the middle cerebral yourself as well. And here's actually how it runs. So this is M1, as I told you, and then this is a superior branch, inferior branch, and these are M2, broadly speaking. And the middle cerebral has to curve around the insular region, and it's very easy to capture the middle cerebral itself. And if you have an infarction or you have a dense MCA sign, it's very easy to pick it in the insular region. And then when the middle cerebral branches curves around the surface of the cerebral hemisphere, these are the terminal branches, or M4. Let's have another example from stroke as well, because sometimes the left insular region, particularly when it can be initially in the initial stroke presentation, like in initial diffusion weighted on the image on the left side, it is very, very subtle. There is a very subtle involvement here, but not the rest of the brain. Usually this guy or lady will present with a motor dysphasia, clear motor dysphasia, and you can just find the very subtle changes here. It is relevant because it looks a little bit edematous compared to the other side, and it has some subtle signal change in the diffusion compared to the other side as well. You cannot maybe confirm it because the scanners are different, but once you find this clear asymmetry, especially in a context of a patient presenting with speech problem, it is likely that there is an ischemia down here. And because for this particular patient, because there is an ACA territory changes as well, there is complete absence on the extracranial, even the extracranial internal carotid, complete occlusion of the internal carotid on the left side. So it might be localizing or outlining the cortical ribbon. It can be relevant to you localizing or you initiate a brisk stroke response for one of your patients. And again, this is another example. So it is just the insula here, and how if you practice with stroke medicine, what score would you give in this patient? What's the aspect score of that? Embarrassingly, I didn't practice stroke medicine in 4 years now. So we start with 10. If anyone wants to write it in the comments, we start with 10. And for every region involved, we subtract 1. So we know that on the insular region, there is outer 3, inner 3, 1 in the middle, and on the top, there are 3. So there is definitely 1 here, let's say 2, and 3. So it is a 7. Yeah, thanks, Dr. Yasser. That's correct. Okay, moving on. The second pathology, common pathology to involve the insular region is the herpes encephalitis, and encephalitis, broadly speaking, but particularly herpes encephalitis. This can look like a normal appearing insular region. However, we need to outline the different structures we need to discuss. So there should be a ribbon, which is not there. So there is a nice ribbon, and that's a nice ribbon as well here. There is a nice, not very nice here, but start to see a thin outline of a ribbon and with underlying white matter hypo intensity in this flare. This is not the case here. So, and you can see an edematous cortex with this edema extending subcortically to the underlying white matter. And it actually muffled the nice three lines we can see. So in this region, so we do know that in this region, you would see an external capsule or extreme capsule and a line of claustrum and an internal and an external capsule. There is no outlining in any of these here, and actually you can see that the edema is encroaching to the gray matter. It didn't particularly affect or didn't preferentially affect the lentiform nucleus, but it extends to the lentiform because the lentiform is here, broadly speaking, if we can say, and here as well. So there is an encroachment of the edema to the deep basal ganglia, and of course there is an outer. This is opercular temporal lobe. It is temporal because it is beyond the sylvian. It is behind the sylvian, so it is temporal. And there are bilateral. There is some bilaterality here, and downwards. This is the amygdala, still not the hippocampus, but the hippocampus as well is involved in edematous, and this is a typical appearance of herpes encephalitis. It's really interesting to see also the top part of the insula here. What is really different is the size of the cortical ribbon. So this one is a nice normal cortical ribbon, but this one is not. So this one is edematous and doesn't look abnormal. Sometimes you will end up with a scan with only this finding, but this is an abnormal, unshakably abnormal finding. And as well, it tends to happen to in a more subtle way in the upper part of the insula. So sometimes you can just have this clue and not a florid presentation like the this example we're using. And let's go again. And this one is again a herpes encephalitis for few good reasons. It's sometimes it can pretty much look like a stroke, but the distribution of the pathology makes you would like to diagnose a herpes encephalitis because there is a preferential affection to the cortical ribbon. And this very part of the insula in the middle cerebral supply is also supplying. This is the very, very branch that curves around the inside of the insula and curves outside. If this branch is occluded, it's likely to involve some areas of the outer frontal and the parietal lobe, which didn't happen. And more interestingly, this is a cingulate cortex. Again, this is a frequent area to be involved in herpes encephalitis, and also here still this is the singulate, but the killer for this case that makes it definite herpes is that there is an involvement to the part of the hippocampus. We will discuss this in some detail in the next session. But this is a hippocampus, and this is supplied by the posterior circulation. This is a PCA supply, and this one is an MCA supply. The good trick that you can always use to distinguish between a patient with an insular affection, medial temporal affection, is that you need to know the anatomy of the middle cerebral versus posterior cerebral, and if the pathology is involving both territories, it is not likely a vascular occlusion. It is likely to be an infectious process, which is this case. And again, this is the hippocampus involved with some diffusion restriction, and the pattern of abnormality makes the diagnosis here. Let's get another case. This is a quite striking finding of again, this is a herpes encephalitis. Interestingly enough, this is more destructive. We can outline here lentiform, but the lentiform here is almost indistinguishable. So there is no lentiform in this part, or actually this very little part is a lentiform, and the rest of it is just destructed by the pathology. And the equivalently, this part should be on this level, but it has been pushed to the side by the edema, and the edema surrounds the white matter tracts, and involves the frontoparietal opercular region as well, extends extensively to the anterior and the inferior temporal region. And this is likely, if you scrutinize the signal, is heterogeneous because the herpes tends to be hemorrhagic, and I believe there are some hemorrhages here as well. What do you think of this pathology? And this guy presenting with a headache and cognitive dysfunction. This is CADASIL. Yeah, thank you.
CADASIL.
This pretty much looks like CADASIL, but the main problem with CADASIL is that it looks like any extensive white matter disease. But what makes the diagnosis here is a phenotype, is a presenting type, and also that this is an unusual pattern of small vessel disease. If we conclude that this is a small vessel disease, it is quite unusual. Yes, that's thank you, Dr. Yasser. This looks like an HIV-associated cognitive impairment. This looks like a post-hypoxic encephalopathy. Pretty much like everything. It really depends on the type of presentation. So this is not synchronous. This is not a diagnostic 100%, but it looks like a CADASIL, especially if the patient is presenting with a typical appearance. You would confirm the diagnosis of a CADASIL with a genetic test, not with a scan, and not with a clinical presentation only. So you need the genes anyway. You need the diagnostic test to make a diagnosis, because it can be quite variable. But the driving pathology of CADASIL is an occlusive vasculitic process. And this occlusive vasculitic process tends to encroach and eat out the brain from outside inwards. So it creeps from the surface downwards, and it starts its creeping process from the anterior temporal pole. So that's why always the anterior temporal pole is involved, and it tends to involve the brain predominantly on the cortical mantle rather than in the deep brain and the deep parts of the brain. The deep parts of the brain are the main pathology in the usual atherosclerotic small vessel disease. For this particular patient, this area of the brain is largely spared from any lacunar-like infarcts or any white matter hyperintensity changes. So it is spared. So it doesn't look like a small vessel disease, a conventional, usual small vessel disease of hypertension related or atherosclerosis. And for CADASIL particularly, it is related predominantly to the cortical vessels, and it starts to encroach downwards. the very reassuring signs towards raising this diagnosis is to involve the anterior temporal lobe. The anterior temporal lobe is very rich in collateral blood supply. There are plenty of anastomosis between the middle cerebral and also between the meningeal and the dural vessels. The outer in the usual atherosclerotic process, this very outer rim of the brain is less involved compared to the deep, which has largely single territorial or single single feeders of arterial supply. So usually the surface escapes the ischemic pathology because of that there are some breach anastomosis always there on the surface of the brain, and especially in the temporal lobe. It is very very rare to have a small vessel disease that starts in the temporal lobe. It needs to extensively involve the frontal and the parietal lobe and the deep regions before you start to see some changes in the temporal lobe. Here, as the pathology is the vice versa. This is extensive pathology in the temporal lobe and starts to involve the other hemispheres to some extent. Relevant to us is the change that happened in the external capsule, which is let's try to localize the insula again. So these are two big gyri, and this is where should the smaller gyri happens, and this is the extreme capsule is spared, and this is a very very tiny claustrum, but it looks like spared as well, and this is the very white matter tracts that are outlining the lentiform are involved preferentially, and this is an external capsule and not an extreme capsule. Usually the extreme capsule lies in very close proximity to the cortex here, which is not the case. And here as well, so we can maybe I'll use a thinner size, and here's an insula. Likely this is the posterior longer gyri and the smaller ones here, and there is an involvement here in this part. There is an involvement to an extreme capsule. The very tiny hypointense line here is a claustrum, and again there is an involvement to the external capsule. Chronic ischemic changes can result in some sort of form of demyelination. It's called an ischemic demyelination, and results into the hyperintensity appearance, as you can see it here, and that's why also you spared, relatively spared. It's not definitely spared, but the signal, at least the signal spared here, and there is a signal spared here between the two. And that's the claustrum of the insular region anyway. Good. Let's move on. What do you think the image on the left can be? Let's say there are plenty of reasons that can cause this appearance, but let's think what comes to your brain first. Excellent. Yes, that's metabolic carbon monoxide poisoning. Excellent. Yes. That's something metabolic because of the particular predilection to the head of caudate on both sides, and to some lesser extent to the lentiform, and toxic as well. Yeah, absolutely agree. Yeah, and the surrounding external capsule is involved, and sparing the extreme and the and the claustrum to some extent, but they are edematous and they are extending though. The insula in this patient, on this particular patient on the left, is spared. It is just the basal ganglia that is preferentially affected, and the surrounding white matter as an extension to the pathology, but not particularly the cortical ribbon. This appearance is of a patient with uremic encephalopathy, acute uremic encephalopathy. Yeah, that's correct. By chance, you're saying renal on the comments, and that's absolutely accurate. On the right side, is another form of metabolic involvement, something that you can very difficult to distinguish from herpes encephalitis, for example. But it depends. It always depends. The interpretation of the image always depends on the context of the clinical presentation. So this is a guy with on the right. This is a guy with uremic encephalopathy. I'm sorry, hyperammonemic encephalopathy tends to have a bilateral insular involvement preferentially, but sometimes so the insular involvement can be involved in toxic metabolic conditions and can be involved in viral pathologies, and it can be involved in vascular conditions, whether they are vasculitic, like CADASIL, if we can say, and middle cerebral territories, which is a very common encounter. Um, I didn't present. I didn't bring some photos of. Occasionally, you might find some very tiny bits of hyperintensity surrounding in the subinsular regions or on the extreme or the external capsule regions. They are broadly non-specific and they have some vercaural spaces. They can be slightly bright, but if you find only these tiny bright spots with a nice anatomy, with a surrounding nice anatomy, and nothing else in the rest of the brain, ignore it. That's fine. It is a non-specific. It is a site of a non-specific hyperintensity, especially if they are tiny and the rest of the architecture of the anatomy is spared. To this point, I conclude, and I'm very happy to discuss any questions. You can raise your questions in Arabic, and that should be fine. I'm stopping the recording as well.